Well, welcome everyone. Welcome. I'm Dr. Johanna Lynch, and it's my pleasure to welcome everyone here this evening. I'm really glad to see you. I'm actually an alumni of UQ from '92, but I met someone earlier who was an alumni from '61. So there's somebody in the crowd who's been supporting UQ for a long time. As an important part of our welcome, I'd like to acknowledge the traditional owners and custodians of the land on which we meet, the Yagara and Turrbal peoples. And on behalf of the University of Queensland, we pay our respects to their ancestors and their descendants, who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society, and I would say their curation of wisdom about how to see the whole person that's important in our topic tonight. I'd like to welcome tonight's guest speakers, Professor Catherine Wallace and Dr. Mark Horowitz, who I'll introduce in more detail later. And I'd also like to just welcome everybody who's here tonight, guests of the university, alumni, colleagues, and people who are interested in this topic. Just some housekeeping. If an emergency comes, we'll go out and we'll go to the end of the corridors and down the stairs, and the loos are on either side of the stairwell. And just a gentle reminder to turn your phones off. And finally, if you want to share about this on social media, hashtag UQ Health Matters is the tag. We will have a question and answer time at the end, so hold your questions until then. And I think you all deserve an extra bit of credit tonight on tonight being a kind of religious occasion in Queensland. And we do have a representative from each side with us, Catherine, who lives in Queensland, and Mark, who identifies as coming from south of the border. And so we'll see how they both hold out. I'm an Australian GP who has a research and clinical interest in whole person approaches to distress. And so this topic is very important as we think about how we approach people in our community. I'm also a senior lecturer in the UQ General Practice Clinical Unit and an advisor and past president of the Australian Society for Psychological Medicine. I'm an associate investigator on the release trial and was one of the very early interviewers of GPs about what do you do when you deprescribe, when this project had its little beginnings about 6 years ago. The Australian Society of Psychological Medicine hosted a lecture by Catherine and Mark about 3 months ago, and the lectures had 750 downloads in the last 3 months. So I think that represents our community's interest in this topic. So let's welcome our first speaker to this important topic. And can I encourage you, as we reflect through this conversation, for you to reflect on how this emerging knowledge might help your community. Professor Catherine Wallace is the main professor and head of the main Academy of General Practice and head of the General Practice Clinical Unit at the University School of Medicine. She is clinically active general practitioner and a fellow of both the Australian College of Rural and Remote General Practice and also the Royal New Zealand College of General Practitioners. Her research centres around patient safety in primary care, in particular safer prescribing in general practice. Her current project includes the Release Intervention Program, which has been designed to support shared decision-making between GPs and their patients to provide step-by-step guidance on the tapering of antidepressant use. Professor Wallace is also the Queensland academic lead for the Partner Network, which connects rural Australians to clinical trials through their local GP. And she's also a founding director of the UQ GP Research Practice-Based Research Network. So please welcome Professor Wallace.
Thank you very much, and it's a great pleasure to be here tonight. And you're all very brave coming out, and Johanna very brave standing there in a beautiful dress, and I'm sort of hugging my coat here. So it's lovely to see you all and to share our research with you tonight. So thanks for coming. So I'm going to be talking a little bit about the question of whether we are overprescribing antidepressants in Australia and internationally, and then about our research. Which is about redressing long-term antidepressant use in general practice, And we even have a theme song for those of you who know Engelbert Humperdinck's Please Release Me, Let Me Go. Release me and let me love again. So that's our theme song, and you'll see why as we go through the talk. But I would like to acknowledge human suffering and distress, and although our research focuses on supporting people to safely stop antidepressants, in particular long-term antidepressants, I want to in no way sort of minimalise the experiences that we all have as human beings and the suffering that we often experience. And as Johanna says, I'm a practicing GP, and I'm I see a lot of people in my practice who come in for a repeat of their antidepressant medication, which in part prompted my interest in this particular topic. So it's big business for GPs. This figure shows you mental health prescriptions in Australia for 2021-22, and you can see that antidepressants are by far and away the most commonly prescribed mental health related medications. And of the doctors doing the prescribing, GPs are prescribing 92% of these medications. So it's usual care for GPs and a very common thing that we see in our practice. Australia in particular seems to have a love affair with antidepressants, and among OECD countries is among the highest users of antidepressants, and that use has increased over the last 20 years and is continuing to increase. To the extent that now 1 in 7 Australians or 1 in 6 adults in Australia are on these drugs, and the use has increased 2.5 times over the last 20 years. I've got an arrow there to the Netherlands, and that's because there are a lot of similarities in the countries between Australia and the Netherlands, and we did some work comparing prescribing rates between Australia and the Netherlands, who've got a much lower rate of use, as you can see there. So we had a student with us for a period of time who helped with this work, and you can see that Australia starts out with nearly twice the rate of antidepressant use in 2013 to the Netherlands, and that our use is increasing over that period of time, over those 9 years, while the Netherlands have done something to keep their antidepressant use relatively steady over that period of time. The increase in antidepressant use is mainly SSRIs. In Australia, you can see that SNRIs and other antidepressants have increased a little bit as well, and the older-fashioned tricyclic antidepressants have remained fairly steady and not used very often in comparison. So the use is largely increasing SSRIs. And in Australia, in particular, that's sertraline and escitalopram. So you can see on the left-hand side of that figure, the two blue lines, and the blue line and the blue dotted line, that's sertraline and escitalopram in Australia. And the lines on the right-hand side are in the Netherlands, where, as we know, they've kept their use relatively stable over the years. And in Australia now, sertraline and escitalopram are in the top 10 most commonly prescribed drugs, up there with the cardiovascular disease drugs and diabetes drugs. So very, very commonly used. When you look at who's being prescribed these drugs, they're more commonly used in older people and more common in women. So we found that people 75 years and older, 1 in 4 people are on antidepressants. And when you look at people age 65 and older compared to people under the age of 65, round about twice the rate in people over the age of 65. And nearly 60% of people in residential aged care were on antidepressants in 2019. And that use in residential aged care is largely mirtazapine. And this variation in prescribing or variation in antidepressant use is reflected in this Australian Atlas of Healthcare Variation, these pictures, 65 years and older on the left and under 65 on the right. And you can see it's confirming just older people, women, round about 1.5 times as likely to be on these drugs as men, and also increased use in poorer and inner regional areas of Australia. And we call this unwarranted variation because it's not something that we would expect to be there. There's no evidence to suggest that depression increases with age. And we know that antidepressants can't treat grief, loneliness, unemployment and abuse. And it's not just Australia, it is internationally a topic of concern. Antidepressant use over this 11-year period, you can see antidepressant use rising. The top blue line is Iceland. Not quite sure why Iceland particularly likes antidepressants, but there's certainly an issue there. So the red line is Australia and the orange towards the bottom is the Netherlands. And as I say, they've kept their antidepressant prescribing rates relatively steady. And so we wondered why this might be the case, why Australia has got higher use than the Netherlands, and why use might be increasing more in Australia at a faster rate when the population, age and sex are similar, so a similar proportion of older people, similar proportion of women. Both countries have got well-developed health systems and good access to primary health care, and clinical guideline recommendations for starting antidepressants are pretty similar in both countries. The differences that we could identify were that in the Netherlands, they've put some effort into initiatives to support safer prescribing in general practice. They've also got closer regulation of the pharmaceutical industry influence on prescribers. They've also got access to non-drug alternatives in general practice, so they employ mental health workers to work in their general practices. And they also have clinical guideline recommendations for stopping antidepressants, recommending slow decrease in drug dose, which is something that we don't yet have in Australia. And when you look at the increasing use of antidepressants internationally, you can see that around about half of the people currently on antidepressants have been on these drugs long-term or are on them long-term being longer than 12 months. And the reason we call long-term longer than 12 months is because most guidelines recommend 6 to 12 months therapy for an episode of major depression. So longer than 12 months is usually not recommended for most people. And there was some work done a few years ago that discovered that the average duration of antidepressant therapy in Australia is around about 4 years. And this seems to suggest that people start antidepressants, rightly or wrongly, and we're not investigating that question tonight, and then they find that they can't stop. And it's really that not being able to stop antidepressants, which is this big issue contributing to long-term use. So that brings us to the question of whether we're overprescribing antidepressants. And one way of thinking about overprescribing would be where people are prescribed medications that they either do not need or want, or where the harm of a medication outweighs the benefit, and that might be a potential harm or a real harm, so a risk, or it might be an adverse effect, or it might be a potential benefit, like preventing something or other happening, or a real benefit, as in, you feel better. And it might also include when a better alternative is available but not given. So when we're thinking about whether we're overprescribing, that's really what we're thinking about, and it's something that prescribers should be thinking about every time they prescribe a medication. Where's the balance lie in the risks and the benefits? Because there's always, there's very seldom that something that's only good for you. There's usually, there's usually a balancing game that you play there. And we can also see that on a population level anyway, the data does not support the idea that antidepressants decrease suicide deaths. So those are suicide deaths from around about 1910 through to around about 2020. And antidepressants came in, the SSRIs and the SNRIs, and later the SNRIs, but early 90s, round about, increasing use from 1990 or so. So in 2020, the Productivity Commission released their mental health inquiry report, and they really came down on the side that we are overprescribing antidepressants. And they recommended as a priority reform addressing adverse outcomes from prescribing practices of mental health medication. And they say that while antipsychotic prescribing in residential aged care is one element of this, arguably of greater concern given its frequency is antidepressant prescribing. So what are these adverse effects? With long-term antidepressant use, it's the sexual dysfunction, which includes decreased libido and difficulty reaching orgasm in both men and women. Emotional numbing, people report feeling dulled, numbed, flattened, reduced positive as well as negative feelings. And obviously that numbing might be a good thing if you're feeling very distressed in the initial phase, but you might not want to live the rest of your life feeling like that. Lethargy, fatigue, lack of motivation, weight gain, increased risk of falls and fractures in older age, and in particular contributing to polypharmacy and all the risks associated with that. And also the related relational and societal effects when people report caring less about others, reduced ability to feel love and affection, which perhaps is part of that emotional numbing kind of, or feeling dulled kind of sense. So in the general practice clinical unit, we listened to that and wrote a paper in the Australian Journal of General Practice, a call to action, which led to collaboration with Joanna Moncrief and then to Mark. So we were very fortunate in that, and then we developed an intervention which we then tested in a Think Aloud study with people with lived experience of long-term antidepressant use. We passed our resources by them and got their feedback to improve the resources, and then ran another iteration of seeking the feedback. And we were very lucky to have funding from the main bequest here at UQ to run that developmental work. And then we were fortunate to get some funding from the Medical Research Future Fund and also the National Health and Medical Research Council to test our intervention in a cluster randomised controlled trial. And so that's what we're doing, and we're still doing that. You wouldn't believe how long it takes to run a trial through to conclusion. But we've got a very good team. That's a photograph of the sort of the on-site team doing that, and very lucky to have 4 of our investigators, or 5 of our investigators here tonight, I think. So thanks very much for your support, guys, too. So this trial's been running in 27 general practices in southeast Queensland, and we're aiming to recruit 540 adults who are on antidepressants for longer than 1 year. So these are not people who necessarily want to stop their antidepressant, they're just people on long-term antidepressants. And the outcomes of our research will include practical resources, where currently there are none, to support safer prescribing of antidepressants in general practice to improve Australian health outcomes. So that's our goal, to try and help make people better. We're not trying to ruin people's fun or make their lives worse in any way. We're trying to help. And our practical resources include printable tapering protocols. So we've developed, with input from Mark, with the scheduling, tapering protocols for 15 SSRIs and SNRIs, and we've got the slower and the faster and the even slower versions, which provides step-by-step instructions for hyperbolic gradual decrease in drug dose, which I'm sure Mark will be talking to us more about soon. We've got a decision aid, and we've got a couple of brochures, trifold brochures, one called Stopping Antidepressants and one on how family and friends can help in this journey. So this is a picture of our tapering protocols. This is the slower one, and you can see it's for sertraline. We've got, people can use the liquids, so they crush the tablet, mix it with liquid. The instructions are on the bottom there, and a QR code linking people to a video of how to make the liquids for themselves. That's the cheaper alternative, but it is quite fiddly. Or use the compounded capsules, which some people prefer, but there is a cost associated with using the compounded capsules, and so not everyone is able to access that resource. So people start at the top on their current dose, and they take a step down every 2 to 4 weeks. The timing is flexible depending on how they're going and how they're feeling. And most importantly, we say to people not to miss the second half of the tapering protocol because people go from 100 milligrams of sertraline down to about 10 and they think, oh, this is easy, I'm feeling pretty good, I'll stop here. But actually, when you look at the tapering protocol set out like that, at 10 milligrams, you're only halfway through the journey. And that's a common mistake that people make. And on the other side, that's the back page of this A4. So we've loaded these into GPs' practice management software, so GPs can print these out from their practice and give them to the patient in front of them. And this, I'd just like to share this story with you. There's been a few little stories in the media and things like that about this topic recently, and I've had several patients reach out to me, also doctors, but this illustrates, I think, quite nicely the issue. So this was quite recently. Thank you for your work on hyperbolic tapering. I want to wean off my SSRI. My GP wants me to reduce it in 25% increments over a few months. However, I've been on an SSRI for almost 30 years and I'm concerned about the risks of reducing so quickly. I want to do hyperbolic tapering. Can you suggest any Australian guidelines or official documents I could provide to my GP to help persuade him to let me try hyperbolic tapering? I'm on sertraline, 100 milligrams. I've been on it for almost 10 years. Prior to that, I was on paroxetine. I was advised to switch ahead of pregnancy, and I was on that for almost 20 years. So I sent them the tapering protocol, and they go, oh, wow, this is amazing, extremely helpful. My GP appointment is in 2 weeks, so I'll let you know how I get on after that. Once again, thank you so much. So I send out the protocol and say, take this to your GP, talk to your GP about this. And then they got back to me and said, I saw my GP again yesterday, and he was open to hyperbolic tapering, ! He'd never heard of it before and was most interested in the tapering schedule you provided. He even ended up commenting that some people do seem to have trouble weaning. Thanks again so much for your help. I'm much more at ease weaning at this slower pace. So there seems to be a real need out there in the community for supporting people on this journey to come off antidepressants. That's a picture of our faster tapering protocol and our even slower one, so lots more steps, smaller steps that you take. And when we did our Think Aloud study, these are just some of the comments that people shared with us. So one participant said, it's really good to have an individual tapering protocol. You feel more like it's set for you rather than generic. I think it takes a little bit of the fear away to know that I can do it more gradually if I wanted to. And so these are our brochures, our trifold brochures that have got information for people about stopping antidepressants and the support that they might need on this journey. And one of the participants said, the fear of relapse is definitely what resonates with me. That's the sole reason I'm still taking them. And another comment was, it hadn't really occurred to me to think about the difference between withdrawal symptoms and relapse. So that's useful information. And I think Mark will talk more about that in his talk. And there's a lot of feedback about, I wish I had that information, and this is quite a sad one, I think. I could have done something. My life could have been quite different. I have suffered weight gain, low sex drive, inability to achieve orgasm, emotional numbing, fatigue, lack of motivation, and sleep disturbance for the last 18 years. I only needed to go through that for 1 year. I wish I had that information. I would not have been on them for so long. And another participant said, I just thought, once you're on them forever. And another one said, I'm blown away by the 1 in 10. That's our decision aid that takes people through how to make a decision about this. And people said it's nice to see it broken down into pretty straightforward pros and cons. And if you show this to your GP, they can gain a lot of information for that too. So this is a resource that people can take along to their GP. And one participant said, I wish that every GP and psychiatrist who's prescribing this drug had this amount of information and awareness. It makes life so much better for people who've been prescribed this drug and want to come off. So I think that's quite a nice, hopeful message about our resources to finish on. And so that just brings us back to the question of whether we're overprescribing antidepressants. And we know in Australia, use is high, it's increasing, and we know there's unwarranted variation in antidepressant prescribing. And so I think it probably does fit the bill that we are overprescribing. and hopefully our trial would do something to help that, in particular the people who've been on them long term and want to come off them. And we're expecting our trial data collection to be complete by the end of next year, and then obviously we can start the analysis and see where we go from there. I'd just like to acknowledge the participants in the trial, all the GPs and practices who are participating in the trial, our steering committee, consumer advisory group, our partners, the funding that we've received from the main bequest, the Medical Research Future Fund and the National Health and Medical Research Council, and also all our co-investigators, associate investigators and partners. So we've got Nancy here, we've got Johanna here, we've got Mark, we've got David, we've got Chris. So they're all part of the team. So it's just great to have you here tonight, guys. So thank you, and look forward to question time.
Thank you so much, Catherine. So now to introduce Mark. Dr. Mark Horowitz is a clinical research fellow in psychiatry at the North East London NHS Foundation Trust. He's a visiting lecturer at King's College London and an honorary clinical research fellow at University College London. In addition to these roles, he is a trainee psychiatrist. Dr. Horowitz earned his PhD from the Institute of Psychiatry, Psychology and Neuroscience at King's College London. He's specialising in the neurobiology of depression and the action of antidepressants. He is the lead author of the Maudsley Deprescribing Guidelines, which Maria let me borrow to bring today, and serves as an associate editor of the Journal of Therapeutic Advances in Psychopharmacology. Dr. Horowitz is also a collaborative investigator on the Release Intervention Program, working to support people to safely stop antidepressant use. Please welcome to the lectern, Dr. Mark.
Thank you very much. I was told not to say that I'm from New South Wales this evening for my own safety, so I'll give me that under wraps. I want to show a video of people talking about their experience taking antidepressants and stopping antidepressants. And I'll say a lot of my work in this area has come from my own experience coming off antidepressants, which was a very horrible experience. And I think had I not been through that, I would have found it hard to believe other people's experience, because it seems so out of what textbooks have said for so long. So I'll leave it to people to put it into their own words. This is a 5-minute montage from people from Britain. If it'll work.
Evie Lewis. I'm a member of LEAP, the Lived and Professional Experience Advisory Panel for Prescribed Drug Dependence. I would like to introduce you to 3 women who will share their experience of taking an antidepressant: Liz, Sarah and Sandra. My first question to them is, can you describe to us what happened in your interactions with your doctor?
Initially, I was on fluoxetine. I recognised that I was suffering sexual numbing. So I spoke to the doctor and asked if there was something else I could try, because obviously this was important to me. So she suggested 15 milligrams of metazapine.
In 2003, about 8 months after I'd given birth to my daughter, I'd gone back to work. I was working full-time, and I started to experience incidents of panic and upset stomachs. My doctor said that I was suffering from social anxiety disorder, and he said to me that what I could do was take paroxetine, this wonderful pill which was going to address a chemical imbalance in my brain.
My mother had been diagnosed with full-blown cancer. She lasted 3 months, but actually the stress of those 3 months and with additional personal issues, I probably went into quite a depression. I was prescribed vortioxetine, and as soon as I started taking it, I was getting adverse reactions. I spoke to the doctor about this, and they increased the dose, which made it even worse, and akathisia then kicked in.
I asked him if I was going to get any side effects from having it, and I was told no.
What advice were you given by your doctor about stopping the drug?
So she said, for the next week, take one every 2 days for a week, and then you can stop.
I recall the doctor saying to me that if I was diabetic, I wouldn't be questioning taking insulin, and this is just like being diabetic. So keep taking the medication.
The GP advised to halve them for a week and then to stop them. 48 hours after my last dose, I said to my husband, I want to kill myself.
By the end of the first week of skipping doses of that medication, I was so ill that I had to go back on it.
What was withdrawal like for you?
Bang, a whole host of symptoms hit, the worst for me of which was agoraphobia and intense 24/7 anxiety.
I felt like I had the flu, I could barely move. I felt really hot, but I was shivering. I had like a chemical anxiety. It was hot, like my skin was on fire, along with like uncontrollable panic. I joined a metazapine group to see if the symptoms were connected to coming off the drug, and it was soon confirmed that I was suffering withdrawal from discontinuing the medication and I should reinstate and start a harm reduction taper. I rang my doctor about this and she told me to get off the group. They don't know what they're talking about.
As soon as I stepped out the front door, I was hit with intense fear.
The anxiety and the fear was 24 hours a day, the inner akathisia. It's like being tortured in your own body and your own mind.
How has being in antidepressant withdrawal impacted your life?
It's made me too unwell to work. That goes on to me claiming sick pay, which doesn't cover my bills.
It was the school summer holidays. My girls wanted me to go out and do things with them. I could not leave the house.
I used to be very outgoing, gregarious, and had lots of friends.
I used to go to the gym 6 days a week. I used to play football every Saturday. I'm not physically well enough to do these things anymore. Like that, it's just been taken away from me.
I started to wonder about whether I'd made proper emotional attachments to my children all the time. I'd been on these drugs 14 years as it was by then.
I've been tapering for 22 months with a year to go. So that's 3 years to get off of a drug that I was only on for 4 months. I never asked for this, and I feel like there's no accountability anywhere. It makes me really angry.
What did you need from the health service that you didn't get?
A bit of compassion. It would have made my experience a little bit better than not being believed from day one. This could have all been avoided if I was aware of the trouble I could get into coming off of this medication.
I would not have gone on the drug in the first place, so informed choice, really. I think doctors didn't have a clue how to taper me off that drug.
They should have at least told me about the withdrawal, not sugarcoat it, that it will be over and done within up to 2 weeks.
All the information is online. There's the NICE guidelines, which I handed everything over to my GP. Medical professionals, I would say, need more training on this subject of how to advise a safe taper so they're all on the same page. If they put you on, they should be helping you get off. I think just leaving us out there to rot with, having to go to Facebook groups is not acceptable.
So I think that gives you a flavour of the sort of issues people experience when they're trying to come off medication. Oops. How do I get? Okay. So actually, I wanted to. I know the British history better than the Australian history, but I think there are commonalities. So how do we end up here where 1 in 6 of the population are on antidepressants? We don't know how to stop these drugs very well, and there seems to be increasing rates of prescribing. So the British story is that there was a campaign called Defeat Depression ran in the 90s and 2000s, and it had 2 main messages. It was on billboards, it was on TV, there was cooking shows, there was celebrities, and the 2 main messages were feeling miserable, hopeless and despairing is a medical illness called major depressive disorder, and people should go see their doctor about this as there are effective treatments. It was fronted by the College of General Practice and the College of Psychiatrists, and they did some research, and the 2 major blocks from the public to these messaging was the public thought feeling miserable, hopeless and despairing is caused by life problems like divorce, job loss, illness and poverty, and any medication that they were offered that affects mood would be dependence forming and difficult to stop. And so the campaign went about trying to attack those 2 points of resistance. And the lines they adopted were depression is a medical illness like any other, like diabetes, and antidepressants are not dependence forming and will be no trouble to stop. So no trouble to stop was put out in all of these different education for the public, for GPs and so forth. And the campaign was widely successful. Depression was accepted as a medical illness. rates of antidepressant prescribing in the period that this campaign ran started off at 3% of the population and ended up at about 15% of the population. So it increased prescribing by about 5 to 8-fold. The campaign was funded by the major antidepressant manufacturers. The College of GP and Psychiatrists thought this is a very useful message. It's helpful to have some financial support, but of course it benefited the drug manufacturers incredibly. Now this illness awareness is self-perpetuating. You need only go on TikTok to see that you don't need money from drug manufacturers. There's just a cottage industry of people talking about that their emotions are best seen through the lens of diagnosis. So what causes depression? For many years alongside this, there's been messaging that depression is caused by a chemical imbalance, thought to be low serotonin or something along those lines, and that antidepressants work by rectifying this underlying chemical imbalance. And GPs or other clinicians translate this to patients by saying antidepressants for depression is like insulin for diabetes. This hypothesis was generated in the 1960s by American psychiatrists who thought that if a drug that increases serotonin improves mood, well, maybe depression is caused by low serotonin. It's been researched for 6 decades. We did a review of this a couple of years ago, and essentially there is no evidence of any differences in serotonin between healthy volunteers and depressed people. The response to our review on this topic was interesting. It was on the front page of every paper in the UK for a few days. But the response from psychiatrists was yawn. We already knew this. We never said this. The Royal College of Psychiatrists has said the old idea that antidepressants correct a chemical imbalance is an oversimplification. We don't support this view. Their leaflet on depression no longer mentions low serotonin. American psychiatrists said something similar. We never said this. It's an urban myth. The American Psychiatric Association said additional experience has not confirmed this hypothesis. But we know that large portions of the public still think this. We know that GPs and psychiatrists and other clinicians still tell this to patients, so it's still out there, although it probably emanated from drug manufacturers. It's out there in the community, and it's something that people internalise in their thinking. So people then often ask me, if it's not serotonin that causes depression, then what is it that causes depression? And basically, I say, well, my grandmother and the public were right. The best studies show it's poverty, illness, conflict with others that causes depression. This is a study by a very famous psychiatrist called Ken Kendler, done in America, that shows on the x-axis is number of stressful life events in a year, job loss, divorce, death of a loved one, diagnosis of a physical illness, and risk of depression on the y-axis. And there's an incredible relationship. The more stressful life events you have, the more likely you are to be depressed. I haven't seen relationships this steep anywhere else but smoking and lung cancer. These are the steepest curves I've seen in medicine, compared to all of the biology that people look at. Neurotransmitters, neurogenesis, inflammation, they're all flat lines. Yes, in this there's personality, which is something like, this is neuroticism that is the different coloured lines, which is something about how sensitive you are to stress. I think of the bottom line as being something like Obama, and the top line something like Woody Allen, if people know who that is anymore. But essentially, and in neuroticism is upbringing, maybe some genetics, so I think there is some genetics in this, but the main story here is what happens in life. People talk about uncaused depression, that's not found here. If you look at people that have no stress, there's almost no depression. Maybe there's 1 or 2% down there. So this uncaused depression that's in every psychiatry textbook doesn't exist in real life. Genetics, if it plays some role, is minor. It's nothing like what it is for height or eye colour. So if antidepressants don't rectify an underlying chemical imbalance or low serotonin, what do? There are all sorts of biological theories out there. They grow new neurons, they reduce inflammation. Most of these are theories, they come from animal studies, they're not proven. The summary of all the studies in this area, done about 3 years ago, found no relationship between any of these variables, neurogenesis, inflammation, and depression. Probably the most famous biological theory is this growth of new neurons. Antidepressants encourage the growth of new neurons. It is not clear if that is a good or a bad thing. There are lots of things that aren't so good for you that cause the growth of new neurons. Blunt trauma to the head, chemical damage and stroke. In the same way as cutting your skin causes the growth of new skin cells, so does damage to the brain. So it's not clear if the growth of new neurons in the brain as a result of antidepressants in animal models is a good or a bad thing. But what is clear is that if you ask people who are on antidepressants, what do they feel? Most of them say they feel emotionally blunted, which Catherine mentioned. That is, their positive and negative emotions are constricted towards the middle. It actually correlates with genital numbing or sexual dysfunction in studies. Because I do a lot of work on these small doses of drugs, if you crush up an antidepressant and swish it around your mouth, it will numb your mouth. So numbing effects is a very kind of common effect of antidepressants along many different variables. Some people said for many years, well, this emotional numbing is because of depression, it's anhedonia. But they did a study last year in healthy volunteers given antidepressants who showed clear signs of emotional numbing. So it's clearly a direct pharmacological effect. As Catherine mentioned, that might be a relief in the short term. If your anxiety or depression is at a 10 out of 10, going down to a 3 may be a relief. But in the long term, there are all sorts of unforeseen consequences on relationships, on sense of self. And it's the number one reason people come to my clinic in London to come off antidepressants is they say, I'm not sure who I am, I'm not sure what I think of my spouse. Because of this numbing. I think Catherine already mentioned these sort of things. If you interview people who are on antidepressants, what do they say they feel? These are the kind of lines: listlessness, lethargy, sleepy, fogginess, loss of libido, inability to care. And you can see how on a study asking people about their symptoms, having these things reduced would improve your symptom scores on a study, and people would conclude that the drug works. But I guess this is interrogating what does work mean. I just spent a minute on this because this is about a broader issue than just antidepressants. I think it's a very useful way to organise thoughts about psychiatric drugs in general, but antidepressants in particular. There's this idea that psychiatric drugs, including antidepressants, can fix an underlying problem, and this is the work of Professor Joanna Moncrief, who talks about the disease-centred model. So a lot of the drugs we use in physical health medicine work in this way. And the classic example is diabetes is caused by not enough insulin activity. You give insulin, you fix the underlying problem, the symptoms of weeing too much go away. Psychiatric drugs are often presented as working in this way, that antidepressants rectify a chemical imbalance like serotonin, or antipsychotics rectify an issue with dopamine. But another way of thinking about the way that psychiatric drugs work is this drug-centred model, that these are psychoactive chemicals. They cross the blood-brain barrier, they affect the way we think and feel. Those effects are superimposed on top of whatever symptoms we have. They may be useful or not so useful. And an example of that is alcohol for social anxiety disorder. If you drink alcohol and you're anxious, you'll be less inhibited and feel more at ease in a social situation. Nobody thinks that alcohol is solving the underlying cause of social anxiety. No one would say social anxiety is caused by an alcohol deficiency. I think the evidence, there is not a lot of evidence that the drugs work in a disease-centred way. We don't know the way that psychiatric illnesses are caused, certainly not for depression. The drug-centred model is an obvious, simple explanation for what is happening. And I think it needs to be excluded before other ones are entertained. And I think when it comes to antidepressants, it's much more likely that these drugs are dampening down emotions rather than fixing any underlying cause. I put that out there because there's always new drugs coming onto the market that propose that they are working in a disease-centred way. So, for example, in America now, they are studying opioids for depression, drugs like methadone and OxyContin. They seem to have a very short memory about what that just caused, which is what it's still causing. And in order, I think it's fairly obvious that if someone takes heroin or a drug that's a derivative of it, they'll feel better. That may not be a good thing in the long term. In order to kind of make this more plausible to the public, they've started writing papers saying that depression may be caused by low opioid activity in the brain, and that giving opioids may rectify an underlying opioid imbalance. It sounds like satire, but I can send you the papers. And I think that is a common approach when it comes to psychiatric drugs. Give a drug that probably causes euphoria or sedation, but talk all about the biology to make it sound scientific, to take attention away from what are its more obvious effects. I'll probably skip through bits of these. How easy are antidepressants to stop? Australian and British guidance said for years that withdrawal effects are brief and mild, lasting a week or two. There's been a little bit of so we could talk about a Queensland, New South Wales head-to-head tonight, but I guess the UK versus Australia, although my knowledge of sport is zero, there's a long-standing rivalry. The UK is well ahead of Australia when it comes to this topic. The UK, in the last few years, has made several updates to guidance. They have changed the guidance to say that patients should be warned of severe and long-lasting withdrawal symptoms from antidepressants. They actually went on TV to say this to the public. NICE, the government body that puts out health guidance in the UK, changed its guidance to say withdrawal symptoms from antidepressants can last longer, including several months, and can be severe. To put this into perspective, in a survey that we conducted in patients in a therapy service, 40% of them said they were unable to stop an antidepressant despite trying 1 or sometimes up to 8 times. Which means, if that extrapolates to the wider population of antidepressant users, it means that there are 1.2 million people in Australia who are on antidepressants because they can't get off them. The guidance has not been updated in Australia based on research in the last few years, and most doctors that I encounter in Australia believe that withdrawal is brief and mild. So I'll just quickly say where that comes from, because I think it's a very important point in this story. Why do guidelines say this? It's because drug companies conducted studies on people who'd been on antidepressants for 8 to 12 weeks. They did those studies to get them approved by the regulators, and when they stopped antidepressants, most people had brief and mild symptoms. Some people already had quite severe symptoms after 8 weeks, but most had brief and mild. And so this is a true statement, brief and mild. The issue is, of course, that most people are on antidepressants for years or decades, and the longer you're on these drugs, the harder it is to stop them. So to me, it's a little bit like a car company crashing its car into a wall at 5 kilometres an hour and saying it's safe, and ignoring the fact that people are driving around at 60 kilometres an hour on the roads. So while this is true, it's very misleading for clinicians and for patients. What's the consequence of this? You had Facebook groups, I think, mentioned in that video. People go to see their doctors. They say they're having terrible trouble coming off their antidepressants, and the doctors say, the guidelines say, brief and mild, you're in pieces, you must be having something else. It's probably a relapse of your condition, or you developed a new mental health problem. And I think that's sometimes when I talk to GPs, I say, I never see any of these issues. When you see the data and half of people have these issues, I think that's because GPs, you can only see what you've been trained to see. If you've only been trained to see relapse, you only see relapse, a return of people's conditions and not withdrawal effects. So people end up leaving their GPs and they end up on these websites. And these websites that guide people off these drugs get 1 million hits a month. 5% of them are from Australia. And they end up telling people to come down much slower. They tell them to come down at about 10% per month, every month. The 10% being on the last dose. So if you're at 100 milligrams, come down at 10 milligrams this month. If you're at 20 milligrams, come down at 2 milligrams. So it gets slower and slower. And we'll talk about later on whether these websites or the Australian guidance is more helpful. Just very briefly, so withdrawal symptoms are physiological symptoms that occur on stopping. They can be psychological or physical because these drugs affect so many different parts of the body. They occur because our brain adapts to the drugs while we take them, and when the drugs are stopped, the body and brain misses the drugs, and that's what causes withdrawal. Some people think that you have to be addicted to a drug to get withdrawal, but that's not the case. You only need to have adaptation. There are these words, addiction and physical dependence, which are sort of used interchangeably, but physical dependence, I'm sure that most people in the audience are physically dependent on caffeine. If you use it every day or most days a week, your brain will become accustomed to it, and when you stop it, you'll get withdrawal effects. Most people are not abusing it, misusing it, stealing from their neighbours to get more caffeine because no one is addicted to it. The same is true for antidepressants. It doesn't give you a euphoria, so it doesn't cause addiction, but long-term users will become physically dependent on it. The flip side of that is tolerance. Sometimes it's said that antidepressants don't cause tolerance, but of course they do, because any drug that causes withdrawal also causes tolerance. The more you're accustomed to a drug tolerance, the more you're going to have trouble when you stop it. There are lots of different symptoms coming off antidepressants. The ones that cause the most confusion are the mood symptoms, low mood, anxiety, irritability, panic attacks. We know that these are symptoms of withdrawal because even in people who are given antidepressants for reasons other than mental health problems, for the menopause, for pain, even healthy volunteers will show these symptoms when they stop antidepressants. There are some very distinctive sensory symptoms like electric shock sensations, little brain zaps. People talk about their brain being switched off or a little bolt of electricity going through their heads. There are some quite severe symptoms. I think people kind of know about headache, they know about dizziness, but there's an increase in suicide attempts in the 2 weeks after stopping an antidepressant. The woman mentioned that for the first time in her life, 2 days after stopping an antidepressant, she wanted to kill herself. This is too soon for it to be relapse, which is normally weeks or months later on. It's been attributed to withdrawal itself. And then I think a very important issue always missed is akathisia. Akathisia is a Greek word meaning can't keep still. It's recognised for long-term treatment with antipsychotics. It's much less well recognised. There's some case studies published that when you stop antidepressants or benzodiazepines, you can develop this incredible agitation. People talk about feeling like their nervous system is on fire, they're often pacing, and people take their own lives because it is such an unbearable state to be in. Because most clinicians are unaware of this as an issue with withdrawal, they see agitated depression, mania, psychosis, and this can be catastrophic to miss this diagnosis. I'll make one point here. People can get long-standing symptoms after stopping antidepressants. So some of those women in the video were talking about months of symptoms. And these sort of people come to their GPs or their clinicians and say, I've been off an antidepressant for a few months now and I feel terrible still. I've got panic attacks, I've got pains, and the doctor says, well, it can't be because of withdrawal because the drug is out of your system. It takes only a few days or weeks. It can't be causing this months later. It must be something else. It must be your anxiety, you must have developed a new mental health problem or a physical health problem. But that involves a misunderstanding of what causes withdrawal effects. It's not the drug leaving the system, it's what has changed in the system and how long it takes to readapt. So I'll give you an analogy to make it more obvious. You go to a loud concert, your eardrums become less sensitive to sound. And when you leave the concert and go out into the quiet street, the voices of your friends sound muffled for a few minutes. And that's actually a sound withdrawal syndrome. The time taken for the sound to dissipate when you leave the concert is a second, you shut the door. What takes a few minutes to settle down is your eardrums take a while to recalibrate to normal levels of sound after being calibrated to high levels of sound. It's an analogy for what happens with exposure to antidepressants and other psychiatric drugs. Antidepressants cause high levels of serotonin, your brain becomes less sensitive to serotonin, and when you stop the drug, it takes a while for your brain to go back to its normal state. And the time taken for that to happen is how long withdrawal symptoms can last for. And there are studies that find that in people that have stopped antidepressants, there are changes to their serotonin system that last for up to 4 years after stopping. So these drugs can leave long-lasting residues in the brain that don't just disappear as soon as you stop the drugs. Go to this a bit quicker. Studies that look carefully at people's withdrawal symptoms find that about half of them experience withdrawal symptoms. There aren't very good controlled studies that look at severity, but in surveys, half of people that experience withdrawal say that those symptoms are severe. I think a very important aspect of this is how long you use the drugs for. So that in people who have used the drugs only for a few months, it's a minority that have withdrawal symptoms and a minority of that have severe symptoms. By the time you're on the drugs for more than 3 years, again, the average use in Australia being 4 years, more than half of people are having withdrawal symptoms and half are saying they're severe. And so the drug companies look down here at these people, but we're seeing these sort of people in clinical practice. I think that's where the disjoint comes from. I'll briefly say this. It's fairly obvious why withdrawal might be misdiagnosed as relapse. Relapse is in red light, surrounded in every lecture about depression, watch out for relapse. Withdrawal has been minimised. When someone comes into a doctor's office saying, I stopped my drug, I'm having panic attacks, I can't sleep, I think most people jump to the conclusion this is relapse. There are a few clues to help distinguish withdrawal from relapse. Withdrawal tends to be quicker in onset after a few days, but withdrawal can also be delayed in onset. It can come off weeks later on because the drug takes a while to leave the brain. It can take weeks. Probably specific symptoms are the most useful to distinguish withdrawal from relapse. So things like dizziness and electric shock sensations are very distinct from anxiety or depression, but really any symptoms that were not present in the baseline condition are likely to be an indicator that it's withdrawal. And sometimes when you start the drug fairly quickly after withdrawal effects have come on, the symptoms go away in a few hours or days, whereas it can take longer for a relapse. Because of a lack of recognition of this condition, many patients are misdiagnosed as having chronic fatigue syndrome, medically unexplained symptoms, neurological disorders, or onset of a new psychiatric disorder. I think an important thing to highlight is protracted withdrawal syndrome. So these are people who spend months and years with symptoms that affect that are neurological, that are psychological, that are somatic. People, as the woman in the video mentioned, people lose jobs, they lose relationships. It can be very debilitating. I think of this a little bit like long COVID. People thought, how can a short virus cause such long-lasting effects after it's been cleared? I think this is a bit similar, although we're talking about long-term exposure to these drugs. And I think that protracted withdrawal is often worse than long COVID. Long COVID was picked up because it was so widespread and because doctors were affected, whereas I think protracted withdrawals had much less recognition, although there is now a diagnostic code in the UK for this condition, so it's being recognised a little bit more there. Most people go to their doctors, they're told this isn't really a thing, this can't be due to the drugs that are out of your system, and so they end up being looked after by friends and family in these peer support sites. So I think this is a major oversight by the medical system. And then very briefly, I'll spend 1 minute talking about how to safely stop these drugs. I guess a key point to make is, there's some broad principles: stopping these drugs more slowly, stopping them at a rate that people can tolerate, and going especially slowly at the end. And I'll just show you why that end bit is so difficult. This is nuclear imaging of the brain of people taking antidepressants. This is a very common antidepressant, citalopram, most commonly prescribed at 20 or 40 milligrams. This is effect on the brain, and the key point is this is not a straight line, it's a curve. So 40 milligrams doesn't have double the effect of 20 milligrams. In fact, a tiny dose like 2 milligrams has about half the effect of 40 milligrams. And this is because when there's not much drug in the system, every milligram of drug has a large effect because all the receptors are open for business, a bit like the game of musical chairs right near the beginning of the game. It's easy to find a seat. As there's more and more drug there, more and more of the chairs are occupied, and so every extra milligram of drug has less and less effect. So this is true not just for citalopram, but for all psychiatric drugs, all antidepressants. Now, the most common way that people are taken off antidepressants, you heard it in the video, is they're told to halve the drug for a couple of weeks and then halve it again before stopping it. It sounds very intuitive and easy to do with existing tablets. If you go from 20 milligrams of citalopram to 10 milligrams of citalopram, there's a small increase in effect. Some people are knocked about by that, but some people can handle it. 10 to 5, there's a bigger effect on the brain. But 5 to 0 is like being thrown off a cliff. The change is about 20-fold the change from 20 to 15. If you imagine walking down this as a path, it starts off like a country stroll, it turns into a steep hill, and then it turns into a near vertical drop. And people who don't understand this relationship think, well, this person really needs the last few milligrams, they're in huge trouble, perhaps they're relapsing. So what makes more sense is to reduce by even amounts of effect on the brain. So I've drawn in this diagram horizontal lines at 20 percentage points of effect on the brain, and that corresponds to these. This is called hyperbolic tapering because this curve is called a hyperbola from high school mathematics. You've got to go down by smaller and smaller amounts, and the final dose before stopping is this tiny little dose, 0.8 milligrams, so that final reduction doesn't cause a bigger change in effect on the brain as its previous reductions. And you can already see this sort of reduction requires all the things that Catherine put up. You can't make up these doses with existing tablets. You have to do cleverer things. You have to get compounded capsules. You have to use liquids. You might have to crush up tablets. But the rationale behind it is to save the brain being dropped off this cliff. And just very briefly, you can actually approximate this kind of reduction by talking about percentage reductions. So this is approximately equal to halving the dose each month. Some people find this too big a jump, so you put it into intermediate doses, and in fact, going down at about 10% of your dose every month seems to work for most people. So what I find fascinating is these online groups, through trial and error, worked out a pattern of coming off these drugs that exactly matches the neuroimaging of the PETs of these drugs. So there's a very interesting convergence between patients' lived experience and what the brain imaging is showing us. And in the UK, this kind of approach to coming off, it's called hyperbolic tapering, has now been adopted by the Royal College of Psychiatrists and the NICE guidelines, and I hope that Australian colleges have had their reservations about it, mostly because it's difficult. I sort of think it is difficult to crush up a tablet, but it's much more difficult to be sick for months in bed. So I think they've made the wrong call. But I hope they'll change their minds and see wisdom. We wrote this book to try to give practical advice to clinicians on how to come off these drugs. So we go through risk factors for different patients, how to work out who should go slower and faster, how to adjust tapers. We give examples of how to come off. It covers all the different formulations in Australia, when to use tablets and half tablets and off-label uses. We hope will be useful for clinicians. And maybe I've gone on too long, so I'll leave that for a moment, unless this comes up in a question. If anyone asks me how effective antidepressants are, I'll give you an answer. So I'll leave it there. Thanks very much.
Thank you so much, Mark. And before you sit down, we're going to move you to these seats over here for a question and answer time. And so this is a time to ask a question of our expert speakers. And I mean that a question, not a discussion, which we can have later over drinks and canapes. And so over to you. If anyone has a question, there's a roving mic ready to come to you.
I was just wondering if psilocybin has been brought up in your discussions, or you know of any studies that have helped people to come off with psilocybin, or...
Hello. Yeah. Look, putting to one side whether psilocybin is helpful for people with depression or anxiety in general. I see a lot of people with protracted withdrawal effects from antidepressants as people suffering with this sort of long-standing symptom, the kind of people in these videos. And some of them try everything. They try every supplement, they try psychiatric drugs, they try psilocybin. In general, the more things they try, the more trouble they get into. And I think it's because they've got a kind of sensitivity or fragility from coming off these drugs that makes their brains a little bit more susceptible to effects than other people. And so I've seen generally didn't react not very well to psilocybin as well as other drugs. And the people that do the best are people that tend to avoid being exposed to more psychoactive drugs. So I think for that group in particular, I think they're particularly sensitive, and it's probably riskier than for the average person.
Any other questions?
Hi, I'm just wondering what happens when you this is addressed to Mark, what happens when you present this information to the psychiatrists in Australia? There's been some very prominent psychiatrists in Australia who suggested using antidepressants as a prophylaxis for depression.
So I haven't presented actually to any Australian psychiatrists. I've presented to a lot of British psychiatrists. I have conversations with my colleagues through the media sometimes. My experience has been very mixed. So I get some psychiatrists come up to me and say, I've actually been doing this my whole career. I take people off very slowly at the end. I use liquids. It's great to see it put in more prominence. It makes me feel like I'm doing what I should be doing. I get people saying, haven't heard of this before, it sounds interesting. I'll look into it. Some people saying I don't see withdrawal very much, I see a lot of relapse. And then I get psychiatrists, generally people who work closely with industry, saying this is anti-psychiatry, this is close to Scientology, this shouldn't be listened to. These patients who are claiming these problems are malingerers, they're looking for legal settlements, they're disgruntled people, they probably have personality disorders, there's a lot of dismissiveness. A lot of those people are the sort of people that spend time writing papers to say, there's nothing to see here, don't worry about this. So it's been the whole gamut. What did you say? You said...
There's actually been an NHS trial to use antidepressants as a prophylaxis for the development of depression in the elderly.
maybe I'll show 2 slides about prophylaxis, sorry, if I can. Do better, but there are no such studies. The longest studies are head-to-head studies that go for about 6 months. And so all those studies are based on what are called discontinuation trials, or sometimes called cold turkey trials. And they involve the following setup. They take people that are well on antidepressants, remitted. They randomise them to either stop or to continue their antidepressant. And they measure relapse or depressive symptoms for 6 to 12 months after people have stopped or continued. And if you put together all these studies, this is in, I think it's in adults and in older patients, but maybe you can look at maybe they've looked at a subset. You find that 40% of people who stay on antidepressants, 40% of people who stop antidepressants relapse, and a bit less than 20% of people who stay on them relapse. And because this is about half, they say it's useful to stay on antidepressants because it will reduce your risk of relapse. But there are some issues with these studies. Number one, it's a very highly selected group of people who respond to antidepressants. That's a minority of people already, so it's already an enriched group. But more particularly, in these studies, most people are stopped in 1 day. The average time that they're stopped is 5 days. I've just talked about stopping over months is useful, maybe even years for some people. Catherine showed reduction schedules that go from 6 months to about 2 or 3 years. Most people will get withdrawal symptoms from this sort of rapid stopping. All of these scales to measure depression, there's things called the Hamilton Depression Scale, the MADRS, PHQ-9. They ask you about anxiety, depression, sleep, appetite. All of those things are withdrawal symptoms. So people that get withdrawal will register on these scales, which means that a portion of these people that are counted as relapsed will actually experience withdrawal misclassified as relapse, which means the difference between these 2 groups is not nearly as big as these studies suggest. And some people have looked at these studies to work out how much is withdrawal and how much is relapse, and they've concluded that it may all be explained by withdrawal effects. In other words, what these studies are showing is not that antidepressants prevent relapse, but that antidepressants prevent antidepressant withdrawal. And to make it a little bit glib, but to make it easy to understand, if you took people who were smokers and randomised them to stop or continue, and you measured anxiety scores, you'd say people that stopped smoking get a relapse of their anxiety disorder, and therefore they should keep smoking to prevent anxiety. And that's because you're ignoring withdrawal effects. So I'm not saying that antidepressants and cigarettes are the same or as dangerous, but the centre of the analogy is that if you ignore withdrawal effects, you can come to perverse conclusions. And so all of the evidence suggesting we should use antidepressants to prevent relapse in old people and in adults is methodologically flawed and I think unreliable.
Thank you. Any other questions? It's over here.
Just to follow on from that, this is perhaps more of a comment than a question, is that part of the problem is how do we define depression, and are we actually defining it correctly? The HAM-D and the MADRS are not so commonly used in clinical practice. They're used a lot in research trials. We use the PHQ-9 a lot here in Australia, with both in general practice, in some of the kind of CBT research studies. I know it's used a lot in the UK in the high intensity and the low intensity therapies to demonstrate an effect. But when you actually look at the questions, I'm feeling sad most of the time. I'm not experiencing pleasure most of the time. There are so many different reasons for that. But today it's become very common to just use those criteria as, right, we need to start an antidepressant. I'm a psychiatrist in public practice. I have debates pretty much on a daily basis with my colleague who shares an office. She's saying we need to start an antidepressant. I'm saying no, we need to look at social interventions. I think until we start improving that dialogue within the mental health sphere, within the health system, and started looking at some of the broader kind of social determinants of health, we're going to be stuck with this problem. And we have also convinced our communities that there is a pill out there if you only look hard enough for it. Psilocybin now has become, one of these kind of magic pills. But we also just have to look at how our rates of medicinal cannabis prescribing in Australia has soared to a huge extent. ADHD clinics are raking in tens of thousands to millions of dollars per year, again based on this idea of a magic pill. So we've got a long way to go as health professionals and as a society about how we deal with distress.
So one thing in response to that, I mean, the PHQ-9 was written by Pfizer. It was written as a tool to encourage antidepressant prescribing. I think when we look at the OxyContin story in America, people who have watched the TV series that portrays it quite well, Dope Sick. It makes it so clear, everyone thinks that's terrible, but it's true for so many different drug types. They created the OxyContin crisis by introducing pain as the fifth vital sign. But PHQ-9 was designed to make it really easy for a clinician in 2 minutes to do a test that then forces their hand, because you get a high score on it. You don't prescribe, you look like, well, you're not doing a good job. But so it really puts pressure on people to prescribe. You're absolutely right. Show that graph about social stresses and risk of depression. It's clear it's being driven by that. As Catherine said, loneliness, poverty, grief is not treated by antidepressants. So we as a society have completely accepted this biomedical framing of depression as an illness in the brain with certain chemicals. We've forgotten the entire social determinants, and we're going further and further in that direction. So I think something needs to happen to put the brakes on and turn the train around.
Yes, go ahead.
Actually, one comment about what you're talking about, that social determinants has fairly recently been recognised in a public way by the World Health Organization, as you know, with some sort of work, and also by the UN. So, the broader organisations are understanding the need for the social determinants, but it's bad for business, I'm afraid. So, including our business of psychiatry and the colleges, in particular. But the question that I had is people that just can't stop. As you might know, I've been working with sort of gradual reduction for 10, 15 years more, and doing it badly, because I've been doing as best as I could. Adele Framer and others who helped us a hell of a lot to do it better, but still some people with the best of intentions and gradual reduction and psychological skills training as well just cannot stop, even though they've got emotional blunting, sexual numbing, etc. Like get down to 150 of venlafaxine, and that's as low as you can go. Having come down from 225, 300, etc. So helping people come to terms with that is a tricky one, and feel like it's not like their fault. And secondly, that this appears to me, and the difficulty with prolonged withdrawal and post-acute withdrawal, it appears to me clinically that this class of drug, SSRIs, SNRIs, is probably the most physically dependence-forming chemical that I'm aware of in the world. It makes opiates look like a picnic, alcohol look like a picnic. Amphetamines are relatively easy to come off compared to some of these drugs in some people. That's the trickiness, of course. About 10% can just drop it with nothing. So the question is how to help people come to terms, and are these probably the most physically dependence-forming substances that we're aware of?
So I'll just say something about the second point first. So I run this clinic in London, helping people come off their antidepressants mostly and other drugs. And I've had a couple of people in my clinic who were heroin addicts, and they said exactly what you just said. They said it was much easier to come off heroin than it was to come off antidepressants. I think it's the regularity of taking it somehow is what, for decades, so that is true. On the first question, I do encounter people that have such incredible trouble coming off, they decide it's not worth it. Sometimes I'll try an incredibly slow taper. I talked about 10% a month. The people out there that go down to 1% per month, sometimes you'll find that too difficult. I think this talks to how profound the adaptation that people make to these drugs, how big an effect it has on the brain. We had a discussion earlier on, how can these drugs have effects that last for years afterwards? But I sometimes flip the question I often get from patients who say to me, are these effects permanent? Have these drugs affected my brain so that it will not go back to normal? And the truth is, I don't know the answer to that because studies haven't been done. Some people who have many years of symptoms after stopping the drugs makes it look like the changes that these drugs produce, are very long-lasting. I think it's behoven on us to tell patients when they start the drugs, you may never be able to stop them. We have in our survey, it wasn't a select group, it wasn't a group of people having trouble coming off their drugs, it was a group of people in a therapy service in the NHS, said that 40% of them couldn't come off their drugs despite trying sometimes a dozen times. So I think when people are considering starting an antidepressant, they should be told, you may have severe and long-lasting withdrawal effects. In fact, they may be so severe you can't get off your medication. And how do you deal with these people who are having horrible side effects and also can't get off? I don't have any easy answer. That's not a very good one. I think,
some sort of acceptance therapy is what's in order there.
You're going.
I've just got a quick question for Catherine. So is there a kind of a business sort of opportunity with compounding pharmacists to really help this? Because as a prescriber, I'm just stuck with these 20 milligram tablets and capsules, and then you write a script, you ring up a compounding pharmacist, it's all so fiddly. But if compounding pharmacists as a cohort in the country were all on board and it was something much more simpler and quicker, you just said, I've got a patient on this dose of this, I want the fast or the slow or the even slower, and they just had it all ready to go. How are we going with getting that ready?
I think that's a lovely idea, and I'm sure there are some compounding chemists or pharmacists in the audience, and I hope they come and talk to me afterwards. But the only sort of proviso with that, just hand it to me and I'll take it each day or whatever, is that you need to have a little bit of flexibility in the tapering often, because there'll be a little bit of a hiccup in life or something will happen and people might want to stay on that same dose for longer than the usual 2 to 4 weeks or whatever it is. And so, some people do have those tapering strips and you just start at one end and finish at the other after however long, but the approach that we're taking is that the schedules are flexible, so people do have that flexibility to go a little bit slower if they want to, But you're right. I can't see the pharmaceutical industry taking this on anytime soon, but maybe they will. That's ultimately the goal, that we'll be able to just prescribe these doses and these schedules, to get people to be able to easily taper and follow the hyperbolic tapering schedule.
Thank you. I think in answer to your question around the compounding, it's a cost challenge to the patient. Obviously, it comes with an increased cost, and that's not accessible to everybody. But with the advent of things like 3D printing, that might be more of an economic way of doing it. Mark and Catherine, I just wondered about your thoughts in relation to pharmacogenomics and withdrawal of antidepressants, and whether you thought that might have any impact on predicting patients who might be more likely to withdraw, and which tapering schedule might be better suited to them.
Well, we've actually got an application in at the moment to look into that, but I think there isn't a lot of evidence to support one way or the other with that. It's more about what drug people have been looking mainly about which drug might suit you to start, and I don't think the evidence is particularly strong there yet either. And there are quite strong predictors of factors associated with who's going to be experiencing more severe or more likely to experience more severe withdrawal symptoms. But there must be something there somewhere, because some people are more individually, within that spectrum, more or less likely to experience withdrawal symptoms. So hopefully we'll get funded and be able to look at that question.
Just like to ask a question for Catherine. I'm coming from the different end of the PET spectrum, where I've been caring for my wife for 8 months with severe withdrawals in close to death scenarios. And it's great that you've got the documentation and you're trying to get GPs on board, but we haven't seen that in the real world. We've seen 3 GPs and they just glaze over when you try to explain. They don't believe it. They give you some cock and bull story what it could be, which is what Mark was suggesting. What can we do to try and accelerate this and help you to accelerate this so that, because the worst thing for us was having no one to go to in the medical. We couldn't trust anyone. When we had to go to surviving antidepressants to get our medical advice, and that's who we're following now, and they've saved my wife's life. So what can we do to try and help you to accelerate this, because too many people are suffering, too many people are dying.
Well, thank you for sharing that, and lovely, great, fantastic question, thank you. I guess the thing is, raising awareness generally. And I mean, one of the things that we've used in the release intervention is to provide the resources directly to patients and tell them, go and take this to your GP. And because GPs want to help their patients, you know, they do. They're well intentioned. They want to help, and but they're just not aware. And it's not their fault. You know, you can see what the guidelines have been. You can see what the published literature and everything that's trying to guide our practice. So I think the way you can contribute is by helping to raise that awareness. You can approach me for a tapering schedule and do like that patient did, take it to your GP and say, you know, I'd like to follow this.
Yeah, it's a big help because until this evening I was unaware of the existence of that. And what we was doing was to buy a few authorised book.
Fantastic.
Taking it to the anything.
Yep.
But they will just, they don't really acknowledge it. I think you're right there. Initially you've got to realise there's a problem and understand it before they can step on and say, okay, what can we do to help?
You're not a journalist, are you? No. So we could get some more stories being published, and you know, get a multi-pronged approach to get the message through. Yeah. Yeah.
And we want it, but we don't really know where to start. Because we go to our GPs, we show them the last book, record, and they're not really interested. And so you sometimes think they don't care because they're really not listening. And it's great what we've got there. I just want to work out how we can accelerate that so we can get to more people. Because we was unaware of it until tonight, so how can we publicise it more ways? Or put it in GPs waiting rooms or whatever, you know, because I don't think it's through.
I know. I mean, I'm sort of torn in a way because I'm having a lot of patients approach me, but also a lot of doctors. And we've taken the approach, we're just going to send the resources out there, and we provide a link now to the website, and all the tapering protocols are there. But on the other hand, we're running a trial comparing the effectiveness, or trying to work out the effectiveness of these resources versus usual care. And we don't finish data collection until the end of next year. So, but, you know, if we have to actually stop the trial early because the cat's out of the bag and everybody just wants the resources anyway, you know, so be it. But at the moment, we're trying to hand them out on a sort of individual basis, in the sense that we get people to register when they go to the website, and then we can see they're not part of our usual care group. But there certainly will come a point, or there may come a point, where we have to really reconsider continuing the trial and not just providing the resources to everybody. But we're still trying to test them. Yeah.
Thanks both so much. That was really awesome. I've got a twofold question. I guess the first is, you very briefly gave us a snippet of a slide about the effectiveness of antidepressants. We're really interested to see that. And I guess the follow on for both of you is, given what you know now, are you still people who commence people on antidepressants? And I guess that's a little bit dependent on what the slide shows.
Do you want me to get the slide?
I mean, I'll
talk to it.
I mean, I can talk about it I'll talk about it 30 seconds, then I'll give you my answer. I mean, you know, very briefly, you know, there are 1,000 studies done on comparing antidepressants to placebo. They all find the same thing, which is a 2-point difference on the 52-point Hamilton Depression Scale. This is I show this picture. It's not all of them. It's 11 studies put together. It just makes it very clear. It does it week by week. You can see red is placebo, and antidepressants are the blue. And you can see that the difference between placebo and antidepressant is about a quarter of the effect of placebo by itself, which is composed of natural recovery, time, regression to the mean, and the placebo effect. You know, when you ask doctors, is this patient better? If there's a difference of 3 points, they say no change. If there's a difference of 8 points, they see minimal improvement. And if there's a difference of 14 points, they see much improved. In other words, 2 points is nowhere near anybody's idea of any kind of clinically important difference. And so that's essentially what the studies show. I won't go into it. There's all sorts of reasons why that is exaggerated. The number one being unblinding. That people who are given the drug will experience some side effects or subtle changes. They'll know they're on the drug. That raises expectations to improve. There's a great study that tried to isolate the expectation effect. They gave everybody in the study antidepressants, and they lied to half of them and said this is an active placebo, it's not really a drug. And they told the truth to the other half. And in that study, the people who were told it's the drug had a 4-point improvement on the Hamilton Depression Scale compared to those told it wasn't the drug. In other words, the expectation effect is twice as big as the difference between placebo and antidepressant. So some people argue the entire effect is expectation effects. Even if it is some real effect, I've already talked about the effect might be because of numbing people's emotions rather than fixing underlying chemical problems. And in the long term, these effects are likely to wear off. So there's all sorts of reasons why the effects are minimal. So, I mean, I basically tell people a lot of what I've told you here tonight. I show people how effective the drugs are. I show them that graph quite a lot. I tell them about withdrawal effects. I show them, we didn't talk about side effects very much. Catherine had a good slide with the weak hose. I tell them about the side effects. I tell them about the difficulty stopping. I tell them about the alternatives. In the UK, in the guidelines for depression, there are 21 treatments that are said to be effective, equally effective and cost-effective for depression, of which 3 include antidepressants. The other 18 involve various forms of therapy, exercise, mindfulness. The number one most cost-effective treatment for severe depression is problem-solving therapy, which I think really speaks to the issues in people's lives that cause them trouble. Problem-solving therapy is name your 3 major problems, name the first step you could take to address each one, come back and report on your progress or difficulties in 2 weeks. So I tell them all that. It's the drugs are legal to prescribe in the UK. They're in the guidelines, so people can ask for them. But I give them all the information that I have for them to make a decision. And most people who haven't heard that, I think that in reality, nobody in Australia or the UK has been given informed consent about these drugs. We've asked people what proportion has been told that you may have severe and long-lasting withdrawal effects. One study a few years ago showed 1% of people were told something about withdrawal effects at all. And I think the latest study showed it was about 6%. But if you have all, now you probably have maybe heard in Australia, the TGA has put out a warning that antidepressants can cause long-lasting or permanent sexual side effects, PSSD, post-SSRI sexual dysfunction. So there are all sorts of issues that people need to consider before starting them, and I think that's what I tell them. And most people weigh the things up and they don't choose antidepressants.
Maybe one last question at the back.
First of all, thank you for such great talks. My question's about ketamine, and I understand much of it is dose dependent, where higher doses is used as an anaesthetic and lower doses have shown improvements in depression. And from my understanding, it's a lot more instantaneous than antidepressants. And so I was wondering the dependence and withdrawal side of things and what your thoughts are for the overall effectiveness.
So ketamine's, I think, a very good illustration of the slide that I showed about disease-centred versus a drug-centred model. So the ketamine that's sort of in the news all the time is this is a nasal spray of esketamine, Spravato by Janssen, and you're right, it does seem to improve people's mood in the short term. The company calls that acute onset antidepressant effects. But the kids in my street call that euphoria. They call that getting high on a Saturday night. There's exactly the same thing that I talked about with opioids, where there's this song and dance. Don't think about ketamine as being a euphoria, think about it as being some kind of brain modifying treatment. And so there's a lot of talk about neurogenesis, effects on glutamate antagonism, but I think most people understand that a drug that's used as an anaesthetic agent for animals, and that people, go into the K-hole for on a weekend, is doing something, euphoric, it's making people high. That's what the studies show. At 4 weeks, it's very hard to distinguish ketamine from placebo.
the company tried to get the studies shorter and shorter. So the usual studies that people do are 6 to 12 weeks to get these drugs approved. The company tried to negotiate with the FDA to do 2-week studies because they knew that the effects are bigger at the beginning and they wear off over time, because all drug effects wear off over time, that's tolerance. And they negotiated to get a 4-week study. They couldn't produce enough positive studies, so they had to renegotiate again. They used one short-term study and one discontinuation study where they stopped the drug and people got worse. Withdrawal effects, of course, ketamine causes withdrawal effects. So a drug that causes euphoria, a drug that causes tolerance, your brain gets used to it, and there are withdrawal effects, and their studies, the Janssen studies themselves show withdrawal effects. The most interesting thing to read about ketamine is going on drugs.com, typing in S-ketamine and seeing people's experiences of it. There's a whole bunch of people saying, I love this drug, I was in the K-hole, I can't believe my doctor's giving this to me, I used to have to go to the local dealer, and there's a whole series of responses saying, this was the most terrifying trip of my life. I was rocking in a chair crying for my mother, and I'm 35 years old. People have also the same sorts of issues that people that misuse the drug. They get bladder issues, their bladder walls stick together, they get something called ketamine bladder. There's a whole series of issues that go on too long. I've written a long paper about this, so I'll stop. But there are all sorts of long-term health issues. So in long-term users of ketamine, there are cognitive deficits, as you might expect, to a drug that kind of fiddles with a very delicate system.
Thank you very much for that question. As we come to an end, I thought there were 2 little anecdotes to mention. One is a patient of mine who told me he went to his psychiatrist to be his legal drug dealer. And the other is a story of a psychiatrist, a famous psychiatrist who brought to the world the concept of attachment and was ridiculed out of the Royal College of Psychiatrists for daring to suggest that breastfeeding did anything other than deliver milk and had nothing to do with nurturing and connecting between mother and child. And so I would see this in a similar light, that you're bringing something to the world that needs to be told and that has strong belief systems around it that will suppress it and in other places make it more visible to the light. So thank you both for a fantastic talk and for everyone for taking time out to be here tonight. We really appreciate your time. So now time for some drinks and canapes next door.